It's literally the simplest thing you can do.
I mean, it's not.
Well, sometimes.
In some cases, look at this.
Some cases,
look
no.
at this probing.
Sorry, what
Let
I
me
meant.
read you these numbers. It's like a phone number. 545-545-544.
What's up, dental peeps? It's your girl Irene here with Tooth or Dare podcast. Hold on to your suction. It's about to get slippery.
Welcome back to another episode of the Tooth or Dare podcast, peeps, with your peep Irene.
And me, Vic.
Welcome back to Op Talk. We're going to answer some questions from IG Clinical Stuff.
Yes.
And you got one on new patient
Probing.
/ perio.
Yeah.
What did our fine follower ask?
So the question is, for new patient exams, is it required that you do a full mouth probe versus a PSR probe? Also, who is responsible for probing, the hygienist or the dentist? I had a dentist in the past say that probing doesn't count unless it's done by a dentist.
Doesn't count.
Doesn't count.
Doesn't count.
He just did it for fun.
It's just extra probing. There's extra points probing.
We didn't have enough in our day, so we just did it for fun.
So we just did it for fun. It was psych, just for jokes, just practicing. What do you mean by it doesn't count? I don't know what that means. I don't want to know what that means.
Yeah.
I do want to say that. So the only thing that to me, it's a calibration thing.
Mm-hmm.
I worked in perio for almost 5-6-ish years. I did 2 extended mat leaves for Dr. Butt, whom I refer to now. And he always did the full mouth probe. But that was a calibration thing. And I get that now because I probe, and I don't know, like I would hope that we're all probing the same and we're tilting 10 degrees into the coal space and our pressure is equivalent. And you don't know until you see the perio chart.
Mm-hmm.
But so that would be my only thing is like maybe it was a calibration thing. Like maybe doc wanted to make sure. And if a general dentist is also doing perio surgery, like one of my old employers would do her own connective tissue free gingival grafts, sinus lifts, direct and indirect, implant placement, like maybe, benefit of the doubt. That would be the reason why. But it definitely counts. Moral of the story is your probing counts. Now the responsibility is, I think, decided based on either your province that you're in or the state board in the United States.
Mm-hmm.
Because like here in Ontario, dental hygienists can work independently. So you are required to uphold your own license.
Yeah.
But in Ontario, we also can't diagnose perio.
I think a lot of places it's the same.
Yeah, but many places, like in Alberta, you can.
Yeah.
In certain places in the United States, you can.
Certain states,
in California, you can. In Maine, you can. And again, like I'll have to double check all of those and list below in the comments. But I think the responsibility then comes down to whose license is being upheld. So I find it really interesting that like in Ontario, dental hygienists can't diagnose perio, but can work independently. And then how are you treatment planning?
Exactly.
It's the really hard part, which was one of the reasons why I decided to have a dentist here full time from the beginning. Some people are like, well, you're not a real independent dental hygienist if you're practicing with a dentist. I've had people say that to me to my face. And I'm like, well, like everyone chooses to do what they want to do and practice and operate the way they want to practice. But I wanted to operate and practice with an actual diagnosis.
Right. Yeah.
And until I can say, patient, you have stage and grade XYZ, like I don't know. Like I don't, how would you know?
Yeah. I would think that they probably just say suspected or.
We do proposed in our chart notes, like proposed AAP.
Right.
And then it gets confirmed.
Yes. Yeah. But if you're an independent without a dentist, it would just stay as suspected.
Right.
Yeah.
Or you refer.
Yeah.
And then you get that referral. You get that back.
Right.
But it definitely counts. And it is strongly recommended, if not mandatory, that new patients to you receive a full mouth probe. I think the only exception would be if someone is coming to your practice from a previous practice and they recently had a full mouth probe and you somehow get that full mouth probing. Now, I request that in my transfer of records. I ask for photos, I ask for full mouth probe, I ask for any relevant chart notes, like whatever they'll give me, I will take because I really want to keep that patient's file together. It irritates me when someone comes in and they're like, well, I've been seeing the same dentist for 20 years. And then I get 2 bite wings and like 1 PA and nothing else. And I'm like, well, where's the baby teeth? Like, where's the rest of the stuff? Like
where's the history of
in medicine that gets transferred. It's all universal. Yeah. You get to know everything from before. They charge for it too. Like
they do.
When I left my family doctor, I think they charged me, don't quote me, but it was like something like $150.
Oh, I think mine was 50.
Yeah, mine was a lot because I'd been seeing him a long time.
Right.
And it was paper charts. So I guess they had to photocopy everything, scan them. Mess. But so a PSR, periodontal screening recording is just that. It's a screening.
Exactly.
So if you're in between your annual FMP, full mouth probe, then you do a screening. But other than that, like it's a full mouth probe all the way.
Yeah. Because how are you going to be able to treatment plan if you don't have all the information?
Correct. Correct. Now, when to probe?
Yes.
To probe or not to probe, and when to probe? At the beginning before debridement. Now, the only exception I would say is like there are times where I'll skip certain sections, where I'll skip like a lower anterior because there's just bridges of calculus, or an upper molar, like a 1.6, 1.7 first molar, second molar. If I just like can't, and I don't want to like traumatize the patient. Yeah. That's the only time. But most of the time they're coming back for SRP anyways. If there's that much visible calculus.
Exactly.
That's not a prophy. Like that's not a maintenance appointment. That's an SRP appointment.
New patient, 40-minute appointment.
Imagine. It happens.
I know it does.
It's happening. Like we see these messages from people and like our hearts are broken.
Yeah. It's awful. It's awful for the patient and the employee, like the hygienist.
Yeah.
Because what do? It's a true dilemma.
Ethical.
Yeah. Puts you in a bad place, puts the patient in a bad place. They're not getting proper care at that point.
It's the billing part that's the troublesome and that provides this, that instills this ethical dilemma. That's all, folks. I can't with words. In the United States, everything is very by appointment billed, whereas here it's segmented into multiple procedure codes. And so it's easier for us because I can say, well, I spent 46 minutes scaling, and 46 minutes scaling is 3 units of scaling, and 3 units is broken down into 15-ish minutes of time.
Yeah.
So like it's easier for us because it's all based on time. If you do a fluoride, the fluoride code. If you do a irrigation, the irrigation code, whatever. It all like creates this pie. Yeah. But in the United States, it's not quite the case. So you've got these like 30-minute prophies that are happening. And yeah, it's more profitable. It is more profitable to see multiple patients in shorter periods of time than to spend more time in hygiene. Yeah. Right? In hygiene. So then it becomes this like
production line.
Do I want to call it a money grab? And the ethical dilemma part is then further broken down into like omission and commission. So now who's responsible for it? Because the hygienist is doing the work, but it's dictated by the Wizard of Oz. Yeah. I just watched Wicked yesterday, so this is my Wizard of Oz reference.
Yeah.
And it's not popular.
No.
You're never popular.
Yeah.
Yeah.
So yeah. In conclusion,
full mouth probe. Always, every year. Yeah. I'll probe early sometimes.
Yeah, me too. Yeah.
Like this happened to me last week. I had a patient who was due for their full mouth probe in February, but I know I'm not going to see them for a few more months. And it's like, oh, I'll do a PSR, but that's not really going to tell me if I'm keeping an eye on something. Yeah. And then I don't want to wait 4 more months. And I had the time. Like it was a maintenance appointment. Oh, that's another thing. I won't I try not to do a full mouth probe during a recall appointment.
No, me
'Cause
either.
There's just so much
Mhm.
going on. So I'll do it in my blue appointments, which is my 3 or 4 month, 4 or 5 month appointments, but never in my yellows. And my yellows are my recalls.
Yeah, I do the same thing.
I'll do a PSR on that one.
Mhm.
And then if there's anything that I'm noticing, I'll bring them back for a 4 to 6 week reeval. And then I'll do just probing.
Yeah.
There's a code that we bill for perio probing and for perio examinations. In Canada, it's a 49101 code on the dentist billing side. And then there's a reciprocal dental hygiene code. But I have a dentist, so I bill the 49101 code, and then the dentist comes in and does the examination.
Yeah.
And there's very specific things that we look for, but we'll talk about perio stuff during SRPs. I like probing.
Yeah, me too.
You? You said that without... yeah, me too.
Me too.
Really?
No, I do actually like it. Yeah.
I like measurable goals.
Yeah. And it's like, it's literally the simplest thing you can do.
I mean, it's not.
Well,
in
sometimes.
some case. Look at this.
Some cases,
Look
no.
at this probing.
Sorry, what
Let
I
me
meant.
read you these numbers. It's like a phone number.
What I meant compared to
Five.
scaling.
What area code is 545? 545, 545, 544, 444, 432. We're at the K9 now. It went from 545 to 444 to 212 with a 636 of recession.
It's the simplest way to obtain data in
She's changed her
hygiene.
tune. It's no longer easy. Now it's just simple.
I said that the simplest thing in your appointment sometimes is going to be the probe. It's a break in your appointment. It's, you know.
Yeah. I find that
break from scaling.
That ends up like on the calibration side. That's where like the perio probe, the perio chart ends up getting like 323'd.
Yeah.
And that's how stuff gets missed. It's
true.
It's not in these like really complicated perio probings where stuff often gets missed. I mean, maybe you're off by a millimeter.
Because you know
or two,
it's going to be there.
Because you know it's like, well, last time it was 674 and 574 and now it's 663 and then it went to 634. So like you know that something monumental is happening on this upper left side.
Right.
But it's the easy 323s that and you're on the fence about the 3 and the 4.
Yep.
It's like, has it passed the black line or not?
Yeah.
So are you a black liner or a not black liner?
If I'm on the fence, I usually go like if it's a 3 or 4, I go with a 4.
Yeah.
I'd rather
overestimate.
Exactly.
Yeah. So it's like if it's just past the black line and then you tilt it and you're like, oh, yeah. That's a 4.
Yeah.
Or you're someone's helping you probe and you're like 323, 323. And then you're like, no. Actually, it's a 4.
Yeah.
Do you say 4 differently out loud? 323, 324.
Yeah, I think I do, honestly. 2, 3, 3, 3, 2, 3, 4.
Just like, what does that mean?
I think I like pause. I'll be like 5, 6,
7,
4,
9, 14. At one point, what do you estimate? My probe goes to 12. I have a UNC probe, I think.
Yeah.
So that's the question. Did we answer it all? Was that it?
That was it. Yeah.
Cool. Great.
Yeah.
Perfect. Well, thanks again for joining us for another episode of Op Talk. Next episode, we're talking about SRP, how we identify that it's needed to be done, what we're looking at, and treatment planning. Till next time, peace out, peeps.
Peace.
Bye.